Thank you, everyone. We will now reconvene the ACIP meeting. We are going to start out the next session with a presentation by Dr. Jefferson Jones speaking about COVID-19 vaccine effectiveness primary series. Dr. Jones.
Good afternoon. Today I'll be presenting a summary of vaccine effectiveness, or VE, for the Mrna and Jansen vaccines using data available from CDC platforms or published via CDC's Morbidity and Mortality Weekly Report, and briefly review a global VE systematic review. Because of time constraints, VE study methods, platform descriptions, Pfizer data, and other details have been included in supplementary slides. Next slide, please. I'll present data by risk group, outcome, product, and by either pre-Delta versus post-Delta time period, or by time since vaccination for evidence of waning. Next slide. This slide summarizes the results presented previously to ACIP. Data suggested VE against infection has declined for mRNA vaccines, while studies for VE against hospitalization have shown small to no reductions. I will mostly focus on recent data today to show how VE has changed over time since vaccination during the Delta period. Next slide. I will first share some recent data on rates of COVID-19 cases and hospitalizations among vaccine recipients. These data sources could not compare rates with controls, and therefore VE estimates are not available. Next slide. 4 state public health departments provided rates of cases by the month of vaccination, age, and vaccine type. These figures only display rates for cases reported for July 2021. Infection rates among Mrna vaccine recipients are shown on the left, and among Jansen vaccine recipients on the right. To display potential waning of protection from vaccination, the x-axis shows when recipients were vaccinated by month. For example, the February cohort was vaccinated in February and diagnosed in July. More time has passed from vaccination to infection for the earlier months. For Mrna, decreasing case rates are seen in the cohorts with more recent vaccinations, such as May and June, suggesting waning protection. And this is consistent in all age groups. For Jansen, denominators are lower and confidence intervals are wider, but increased case rates are seen among people vaccinated in March versus people vaccinated during other months. Younger age groups had higher case rates in all months for both vaccines. Rates were higher among Janssen recipients than among Mrna recipients. Hospitalization rates were not available from this data source. For hospitalization rates, a different data set is displayed. The Cosmos data set utilizes data from over 700 participating hospitals and 10,000 clinics in all 50 states that use the Epic health record system. More information on this data platform and methodology are shown in the supplemental slides. The figures are designed similar to the last slide and display data for COVID-19 hospitalizations during August 2021. For Mrna on the left, COVID-19 hospitalization rates did not substantially differ depending on the month of vaccination. For Janssen on the right, hospitalization rates were higher in those vaccinated in the most recent 2 months, June and July. For both vaccines, rates were higher among those aged 65 and older, shown in gray, than among younger age groups, shown in dark and light blue. And rates were higher among Janssen recipients than among Mrna recipients. Next slide. Next slide, please. So the first risk group is people aged 65 years and older, and I'll present the VE by age groups for comparison. Next slide. New York State updated their data from a prospective study of adults in New York that were published in the MMWR and presented at a previous ACIP meeting. VE calculated using a hazards proportion method are now presented by vaccine product and month of vaccination. These results are included approximately 155,000 cases and 40,000 hospitalizations. Mrna is displayed in the top row and Janssen is displayed in the bottom row. Each column shows a different age group. Each color represents a different cohort based on the month of vaccination. And a dashed line that increases over time shows the percent specimens that were the Delta variant. For Mrna, all ages had similar trends, with decreases over time as Delta became the prominent variant in circulation. In August, small differences in VE were seen by cohort, with lower VE seen among those vaccinated in January and February, shown in blue, compared with those vaccinated in April, shown in green, suggesting waning in VE against infection. For Jansen, VE decreased over time, particularly for younger age groups. VE was higher in those vaccinated more recently, but 95% confidence intervals shown in the shading were wide and frequently overlapped. In general, for both vaccines, no large differences were seen in VE by age. Next slide. This figure is similar, except it shows VE against hospitalization for New York. For Mrna, shown on top, among persons aged 18 to 49 and aged 50 to 64 years, shown in the top left and top middle, no substantial decreases in VE were seen. For persons aged 65 and older, shown in the top right, Mrna had a small decrease, but remained at above 94%. VE for Jansen was lower than VE for Mrna. For Jansen, shown on bottom, no clear decreases in VE over time or in VE by month of vaccination were seen. For both vaccines, VE did not differ by month of vaccination, suggesting no waning in VE against hospitalization by month of vaccination. And also for both vaccines, VE for age greater than 65 years was lower than VE for younger ages. Next slide. The ICAT platform was presented previously and has been updated. It is a nationwide community-based platform utilizing COVID-19 testing performed via pharmacies and partners. VE is calculated using a test-negative case control design. This page shows VE against symptomatic infection for the Mrna vaccine. For each figure, the x-axis is the number of days from final vaccine dose, and each figure displays VE for a different age group. VE against symptomatic infection is lower during the Delta period, shown in red, than during pre-Delta, shown in blue, and it wanes during both periods. For age greater than 65 years, VE is lower than for other age groups, but no clear trend over time is seen. Next slide. For the Janssen vaccine, there is a lack of sufficient pre-Delta samples. VE against symptomatic infection during the Delta period appears stable over time, and there are no clear differences by age, but confidence intervals are wide among the older age groups. Next slide. Supernova is a platform with data from 5 VA hospitals using a test-to-negative case control design that has previously been presented, updated with data up to September 17th, and stratified by age group, shown on the left, shows that VE remains lower in people aged 65 and older at 78% in light blue than in younger ages at 95% in dark blue. Analyzing VE by time from vaccination among all ages, shown on the right, shows a decline in VE against hospitalization. VE is lower in people vaccinated 120 days or more prior at 82% in light yellow than in those people vaccinated more recently, and 90% in dark yellow, but 95% confidence intervals overlap. Next slide. In summary, for VE among people aged 65 years or older, for Mrna, VE against hospitalization is lower in people aged 65 years or older compared with VE in younger adults. Some studies show moderate declines in VE against infection and small declines in VE against hospitalization. For Janssen, VE is lower compared with mRNA vaccines for both VE against infection and hospitalization. The evidence of VE over time is inconsistent across studies, and fewer data available and VE estimates are less reliable compared with mRNA vaccine estimates. Next slide. The next group for discussion is adults aged less than 65 with underlying medical conditions. The data I will show has excluded those with immunocompromising conditions because that group has already been authorized to receive a booster dose. Next slide. The IV network is a collection of 21 medical centers in 18 states. VE was estimated using a test-negative case control design. VE against hospitalization for Mrna for adults is displayed. On the left is VE for those without chronic conditions, and on the right is for those with at least one chronic condition. VE is displayed by age group. Light blue shows VE for people vaccinated more than 120 days prior, and dark blue shows VE in people vaccinated more recently. For people with no chronic conditions on the left, VE is higher for all ages, and VE remains high for people vaccinated 120 days or greater prior. For people with chronic conditions on the right, VE is lower than for people without chronic conditions. VE is mildly lower for people vaccinated greater than 120 days prior among the chronic condition group, but 95% confidence intervals overlap. Next slide. For the Janssen vaccine, insufficient data were available to calculate VE by age and by time vaccinated. VE in people with chronic conditions on the right and shown in light yellow was lower than VE in people without chronic conditions on the left and shown in dark yellow, but again, confidence intervals overlap. Vaccine efficacy for Janssen was lower than the VE for mRNA vaccines. Next slide. The VISION network involves over 185 hospitals. VE was estimated using a test-negative case control design. VE against emergency, department, and urgent care visits among adults without chronic conditions are displayed. For VISION data, shown in this and the following two slides, Mrna estimates are shown in orange and Jansen are shown in gray. Data is stratified by age, with the left showing age 18 to 44 years, the middle showing ages 45 to 64 years, and the right showing ages 65 years and above. The x-axis shows the time since last vaccine dose. In all age groups, Mrna VE is higher than Janssen VE. In all age groups, Mrna VE shows a modest waning trend, while for Janssen, there was no consistent pattern of waning. Next slide, please. This slide displays VISION data estimates for VE against emergency department and urgent care visits for adults with chronic conditions. In all age groups, Mrna VE is higher than Janssen VE. For Mrna, in the 45 to 64 year and 65 and older age groups, the orange bars in the middle and on the right, modest waning in VE is seen. For Janssen, shown in gray, no consistent waning is seen. For both vaccines, waning in VE is more pronounced in the oldest age group. Next slide, please. This slide displays VE against hospitalization and is for adults with chronic conditions. In all age groups, Mrna VE is higher than Janssen VE. In all age groups, for Mrna, VE shows a modest waning trend, but it is most pronounced among ages 65 years and older. Janssen shows no consistent waning in VE. Next slide, please. In summary, for adults aged less than 65 years with underlying medical conditions, for Mrna, there is a mild decline in VE against hospitalization and against emergency department and urgent care visits, but the VE remains high. For Janssen, the VE is lower compared with VE for mRNA vaccines for both infection and hospitalization. There is no consistent evidence of waning. Next slide, please. Next is data for VE for workers employed in occupations with a high risk of exposure to SARS-CoV-2. Next slide, please. So this data has not been updated and was previously presented. Heroes Recover includes a cohort of over 4,000 healthcare workers, first responders, and other frontline workers in 8 U.S. locations who were vaccinated almost exclusively with the mRNA vaccines. In the top box, results show the VE against infection decreased with increasing time for vaccination from 85% to 73%, but confidence intervals overlap. In the bottom box, VE during Delta was 66%, less than VE during pre-Delta, which was 91%. The study did not have sufficient power to look at time since vaccination during both the pre-Delta and Delta periods, and no difference in VE was seen between the mRNA products. Next slide. Next slide. I will briefly preview an ongoing systematic review conducted by WHO and the International Vaccine Access Center at Johns Hopkins University. Next slide. The inclusion criteria are listed in extra slides. I'll display portions of the resulting forest plots for the Mrna vaccine and then the Janssen vaccine. They show that CDC results are consistent with other published studies. Studies that were captured included those from the United States, United Kingdom, Canada, and Qatar. Most studies are pre-Delta data, and they also include published data from CD studies, some of which have been presented. The forest plots of VE against death and severe disease, including hospitalization, for Mrna, showed VE of 89 to 100%. Next slide. For Mrna, VE against any infection, displayed in the forest plot on top, ranged from 75 to 100%. VE specifically against asymptomatic infection, shown in the forest plot on the bottom, ranged from 70 to 90%. Next slide. I will review one preprint study conducted in the United States which examined VE over time since vaccination. It was funded by Mrna and used a test-negative design with Kaiser Permanente Southern California patients. 8,153 cases were diagnosed between March and July 2021, were each matched with 5 controls. The VE against infection with Delta, shown in green in the figure on the right, declined from 94% for those 14 to 16 days after the second dose, and declined to 80% for those that were vaccinated 151 to 180 days after the second dose. VE in individuals aged 65 or older at 75% was lower compared with the VE in younger persons at 88%. VE against hospitalization over time was not presented in the manuscript because small numbers of hospitalized cases, was noted to be greater than 96% for Delta and non-Delta. Next slide. This slide includes the forest plots for the Jansen vaccine. Again, CDC studies are included, and most are pre-Delta. The VE against severe disease shown in the top forest plot ranges from approximately 60 to 85%, which is lower than the estimates for mRNA vaccines. VE against any infection or symptomatic disease in the bottom forest plots ranged from 12 to 95%, but many studies had wide confidence intervals because of small numbers of people who had received the Janssen vaccine. Next slide. I'll highlight again one study that examined VE over time conducted in the United States. A Janssen-funded cohort study using Health Verity insurance claims data matched approximately 390,000 vaccinated individuals with approximately 10 controls each by location, age, sex, and comorbidity index. VE was estimated using a proportional hazard design. Medically attended COVID-19 was defined as COVID-19 ICD-10 codes or PCR positive results, and COVID-19 hospitalization was defined as a discharge diagnosis of COVID-19 or any COVID-19 positive test within 21 days of hospitalization. Of note, displayed VE are estimated after assuming an underreporting of 40% of vaccination, and the correction increased the VE point estimates by approximately 8 to 10%. The study found VE against medically attended COVID-19 and VE against hospitalization to be stable over time. VE was found to be lower in people aged 50 years and older than in people aged 18 to 50 years. Without correcting for unreported vaccination, VE against infection for age 50 years and older was 65%, and for ages 18 to 49 years was 75%. And for VE against hospitalization for ages 50 years and older, the VE was 71%, and for ages 18 to 49 years was 79%. Next slide. Several limitations leading to biases or potential biases should be considered for VE studies in general. Individuals prioritized for vaccination early in vaccination campaigns were often those at higher risk for SARS-CoV-2 infection and or severe COVID-19, such as frontline workers, older people, and long-term care facility residents. This could lead to overestimations of waning of VE when comparing VE in those vaccinated early with those recently vaccinated. However, high-risk groups may practice prevention measures more frequently and lead to overestimation of VE estimates. After vaccination, people may change their behavior, engaging in riskier activities or seek testing less because of confidence and protection. However, some studies report vaccinated people practice preventive measures more frequently, and the use of a test-negative study design partially addresses test-seeking behavior. As more time elapses since vaccination, it is possible that there may be more misclassification of vaccine status, whereby vaccination status is not documented for some people, falsely assigning them to the unvaccinated group. And lastly, SARS-CoV-2 infection and subsequent population infection-derived immunity will increase over time in the unvaccinated group, resulting in protection from further infection, leading to an apparent waning of VE. Next slide. Next slide. In summary, Mrna VE against infection declines over time, Both circulation of the Delta variant and increasing time from vaccination appear to contribute to these declines. For people aged 65 years and older, VE against hospitalization is lower compared with VE in younger adults. Some studies show moderate declines in VE against infection and small declines in VE against hospitalization. For adults aged less than 65 with underlying medical conditions, there is a mild decline in VE against both hospitalization and against emergency department or urgent care visits, but VE remains high. For people in occupations with a high risk exposure to SARS-CoV-2, we currently have no Moderna-specific data available at this time, but for mRNA vaccines, one study showed VE against hospitalization is declining. For the Jansen vaccine, VE against both infection and hospitalization is lower compared with VE for the mRNA vaccines. Evidence of waning in VE over time is inconsistent across studies. However, fewer data are available, and VE estimates for the Janssen vaccine are less reliable. Next slide. Thank you to the many site PIs and teams and others at CDC and other organizations that have helped putting this data together. Next slide. Thank you.
Thank you, Dr. Jones. This presentation is now open for questions. Well, while we're waiting for some questions, I'll just say thank you for a terrific overview of the vaccine effectiveness data. I would say, like, what I take away from this is the vaccine is incredibly effective, and then there are some differences by vaccine type, by time since vaccination, and of course with the variants. But overall, it's really reassuring to see all of this data. Dr. Long?
Yes, thank you, Dr. Jones. This is really what it's all about, and yet it came so fast and furious, and also went from protection or effectiveness against infection and hospitalization and then severe disease. And you outlined it very clearly, but I think we don't want to be confused by protection against infection, as that has not been the goal of this vaccine. And I don't think these vaccines are capable of this, at least for a very long time after any given immunization. I do, and so what, and thank you, Dr. Lee, for your summarizing what you think you took away. May I say what I think I took away? It appears as if the Mrna vaccine protection has longer legs, but it starts out inferiorly. And so there is a real need to protect people who have received Janssen vaccine, especially those who are older. And as far as the others, I think I get it for everybody. Those over 65, for sure, are with Mrna, are folks that seem to have waning effectiveness, although, you know, that's the group that's least likely being infected right now. So it is all confusing, as you have said. The part that I am not clear on, and I think we all have slightly different takes on, is the healthcare workers and frontline workers. Can you maybe show us those slides again and not focus on infection, but just severe disease? I suspect that's slide 24, 5.
Please go to slide 22, please. So the data that we have in the HEROES Recover, which is specifically cohorts that cover healthcare workers and frontline workers, only presented data to infection. So at this time, we don't have VE against hospitalization data, but we presume it to be similar to VE for the general population. And as you said, more severe waning of VE against infection, with studies showing some studies showing small waning in VE for younger age groups, while others showing no waning for VE against hospitalization. And if I could just clarify one thing early in your comments, did you mean that the VE for Janssen is overall lower than the VE for the mRNA vaccines, correct?
Yes, is that correct?
Yes, and that has been fairly consistent across various study platforms and the WHO Global Systematic Review.
Yes, thank you so much.
Dr. Talbot?
That was an amazing whirlwind of VE data. And I, as someone who does VE, I understand how difficult these studies are, especially in this compressed time frame. I am worried, however, that the persons who were, and you did mention this, that were vaccinated first were much sicker than the ones that were vaccinated later. And so I feel like this data is really comparing apples and oranges, and I don't know if it's applicable. So I would just, even with the healthcare workers, many hospital systems were counting number of comorbid conditions, and those with 6 or more comorbid conditions could go first in the line. So I really, even looking at just the healthcare workers, that's an issue. The other thing I think with the Delta variant, if you look at that on the slide that you currently have on, they're really big confidence intervals, and I don't know how to interpret that. So I'm sure that there is some waning. I'm sure there's a change in the Delta variant that have impacted VE for Mrna, but I don't think it's quite as striking as what we've looked at in these slides. Thank you.
Dr. Doolin is going to respond, and if Dr. Jones would like to add anything, we'll have him do so.
Hello, Dr. Talbot. I think you raise a very good point about potential confounding in the health status of people who received vaccine earlier in the vaccine rollout and how that might be affecting VE that we're observing over time since vaccination. But I think the Mrna long-term study of their randomized controlled trial recipients and the follow-up where they crossed over and vaccinated placebo recipients does provide some informative data here in that, these were all trial study participants who were randomized at the beginning, and in that study, which was presented earlier by Mrna, they did observe a slight decrease in VE for people who were vaccinated earlier in the program.
I guess I would only add that
Just so I recall, those were symptomatic infections, but was not severe, correct?
That's correct. That's what they presented.
Thank you.
I would only add that there's been two kind of sets of evidence, both the pre-Delta versus Delta, and then the time from vaccination. And we could also take into account that VE in the setting of Delta appears to be lower, independent of timing of vaccination. So.
Thank you. Dr. Sanchez?
Well, thank you, and thank you, Dr. Jones. I agree. This was very complete but very quick presentation, but really very important. And just getting back to Dr. Long's comments, because I think it really is, it's very important to distinguish infection versus severe hospitalization, but severe disease, i.e. hospitalization and certainly death. And when I look at what the Heroes Recover that study that looked at infection, these are workers employed in occupation with high risk of exposure, but some of them may also have had some chronic or some underlying conditions that may have posed higher risk. And I just think it's important to try to separate some of those out as well from the healthcare workers, because we're going to be asked to a lot of the healthcare workers are young, otherwise healthy individuals, and then we have to weigh the risks of the pericarditis, myocarditis, or the thrombotic events with the Jansen product. So I think that looking at more severe disease in these individuals is important and over time, and also B, trying to see otherwise healthy healthcare workers and their risk and the vaccine effectiveness in those. Thank you.
Because we can work with the platform to see what data could potentially be developed on that front. But I think for now we could compare with the other platforms, including New York State, including Ivy and Vision, that also looked at younger age groups, or specifically the Ivy and Vision groups that looked at younger age groups with chronic conditions. And there's likely applicability to those that were kind of in the general population versus the healthcare worker group, showing, again, VE decreasing more for infection and having smaller declines in hospitalization.
Thank you. Dr. Chen.
Thank you again for such a beautiful presentation of all this data, and it's very dense. One thing I guess we're talking about how we're synthesizing this information is that as I look at this, we're trying to separate out different types of risk. And here in Heroes Recover, we're looking at risk due to occupation, which is risk of, acquisition of the virus, and not really host, factors, which is kind of what we're talking about for the comorbid conditions, and which could then explain like faster loss of the immunity or something like that. So I'm just bringing up the fact that if the person has a risk-based, increased risk because of their occupation, what might be kind of implicit in some of the data is that, it might be a failure of following NPIs, non-pharmaceutical interventions like masking, ventilation, physical distancing, those sorts of things. And so I guess, in our discussion of talking about these booster doses, I also didn't want the American public to kind of somehow have the message diluted out for the importance of layering on all of these non-pharmaceutical interventions that I think that continue to be super important, and especially for those with occupational risk or others where they have a higher risk of encountering the virus. So again, I'm encouraged by the data. I completely agree with my colleagues that have said that it's really important for us to look at more prevention of severe disease rather than any infection. And again, it might be too much to ask for a vaccine, either a primary series or the booster, to prevent all forms of infection, especially if we're talking about the very mild disease.
Thank you, Dr. Chen. We'll move on to Dr. Daly and Dr. Duchin, and then we'll move to the next presentation.
Thanks so much. Dr. Jones, thanks for the presentation. One quick clarifying question. What's the current estimate for vaccine efficacy for those who received Jansen and have chronic underlying conditions?
So I'd go to slide 19.
I thought it was maybe 60-something%, but I just wanted to be sure.
Yeah, so Jansen is shown in gray, so depending on which age group you're looking at, and these, in the extra slides, you can see the confidence intervals and more details on this, but depending on the age, in this age group, it ranged somewhere between 60 and 80%.
Okay, thank you.
Thank you. Dr. Duchin?
Thank you. Jeff Duchin, Infectious Diseases Society of America. I'm interested in the issue of potential confounders influencing our estimates of vaccine effectiveness over time. And I was wondering if there is a way to better characterize or quantify the impact of increasing risk behaviors or increasing natural infection among control groups that would both lead to decreased VE estimates. Can we do a sensitivity analysis or is there another way to sort of understand the extent to which these may be influencing our current estimates? Thank you.
Thanks for the question. I'd like to defer this one to Dr. Ferdinand, who's been with the Vision platform, has been looking at this in detail. Dr. Ferdinand?
Hi there, I hope everyone can hear me. Good questions, Dr. Duchin. Specifically, I know we have quite a challenge in trying to assess differences that might be associated with changes in risk behavior. As you know, these things are really hard to characterize. And we, for instance, I'm affiliated here with the Vision platform. We don't, for instance, have much data that characterizes individual behaviors like that. So I think that's a limitation of our data. I'm not sure if anyone from the other platforms wants to chime in about whether they're able to take a look at that.
Yeah, I think it's a common limitation in many of the larger, more powerful platforms that risk behavior data is very difficult to capture.
Mm-hmm.
Well, but could we, for example, model what a 10% change would be in risk behaviors and how much of an impact that would have on our vaccine effectiveness estimates?
Thanks for the suggestion. We'll discuss it with our platforms and we'll get back to you. Thank you.
All right, thanks everyone. Let's move on to the next session, which is Dr. Kathleen Dooling, who will give us the evidence to recommendations framework discussion here.
Thank you, Dr. Lee, and good afternoon, everybody, and especially ACIP members. I recognize you are at the end of a very long 2 days of meetings. So today I'll be reviewing the evidence to recommendation framework for Mrna and Jansen COVID-19 vaccine booster doses. Next slide. As the ACIP members have come to expect, we'll walk through the evidence and information as it pertains to each of the ETR domains. Next. And as a reminder, vaccine policy development is conducted in close coordination with FDA and starts with data evidence review, followed by FDA regulatory allowance, which was received yesterday, followed by ACIP deliberation and recommendations for input into CDC vaccine policy. Next slide. And as a reminder, CDC currently recommends the following groups for Pfizer-BioNTech COVID-19 vaccine boosters. So the following recipients of a Pfizer primary series should receive a single booster dose at least 6 months or 6 or more months after completion of the primary series. So those are persons who are 65 years and older, persons 18 years of age and older, and who reside in a long-term care setting, and persons aged 50 to 64 years with underlying medical conditions. In addition, the following recipients of the Pfizer primary series may receive a single booster dose 6 or more months after completion of the primary series, based on their individual risks and benefits. So that's persons 18 to 49 years with certain underlying medical conditions, as well as people aged 18 to 64 years with increased risk for SARS-CoV-2 exposure and transmission because of occupational or institutional setting. Next slide. So here are the policy questions that we aim to address today. The first being, among risk groups for whom CDC recommends Pfizer-BioNTech booster dose, should those who received a Mrna COVID-19 vaccine primary series be recommended to receive a single Mrna COVID-19 booster dose at 50 micrograms 6 months or more after completion of the primary series? The second policy question being, among people who are aged 18 years or older who received a Jansen COVID-19 vaccine for their primary COVID-19 vaccination, should a booster dose of Jansen COVID-19 be recommended 2 months or more after receipt of the initial dose? Next slide. So to give you the big picture here, more than 189 million people in the U.S. have been fully vaccinated so far. Approximately 105 million, or about 66% of fully vaccinated, have received the Pfizer primary series. Approximately 70 million, or roughly 37%, have received the Mrna primary series, and approximately 15 million, or rather 8%, with a dose of Janssen COVID-19 vaccine. Next slide. Now let's discuss the public health problem. Next slide. So this slide shows the trends in the daily number of COVID-19 cases in the US, now totaling almost 45 million cases since the beginning of the pandemic. The current wave, during which Delta variant has predominated, peaked in early September and has been on the decline since then. Next slide. Similarly, the daily trends in the number of hospitalized COVID-19 cases has been declining in the US over the past several weeks. Next slide. This series of figures is an update to COVID-net data previously presented to ACIP. This is an age-adjusted weekly hospitalization rates from January to August. Hospitalization rates among fully vaccinated people are shown in green, and hospitalization rates in unvaccinated people are shown in blue. In July and August, as hospitalization rates dramatically increased among unvaccinated, rates increased only slightly among the fully vaccinated. Among the various age groups, hospitalization was 9 to 15 times higher among unvaccinated compared to vaccinated. Next slide. Hospitalization, of course, is not the only debilitating consequence of COVID-19. Long COVID conditions are a wide range of new, returning, or ongoing health problems people can experience 4 or more weeks after first being infected with SARS-CoV-2 virus. The prevalence of post-COVID-19 conditions among both vaccinated and unvaccinated has been reported at between 5 and 80%, depending on the study. The prevalence of long COVID-19 among fully vaccinated persons who develop COVID-19 ranges from 5% reported in a study out of the UK in adults to 19% in a study of Israeli healthcare workers. And among COVID-19 cases in that same UK study, the odds of developing long COVID were reduced almost by half among fully vaccinated compared to unvaccinated cases. Next slide. Switching gears now, I'd like to review a summary of the VE of the primary series of both Mrna and Jansen. As Dr. Jones emphasized in his detailed presentation, waning of mRNA vaccines has been more pronounced against infection, shown in this graph in blue, than against hospitalization, shown in red. Compared to the pre-Delta period, vaccine effectiveness has generally been lower in the Delta period. Next slide. As demonstrated in this figure of published studies, mostly involving mRNA vaccines, waning against infection was most pronounced in July during the Delta wave. Nanduri et al. Reported VE among nursing home residents that was lower and found lower than in what was found in younger adults, and it waned over time. Next slide. Vaccine effectiveness against hospitalization, on the other hand, has remained fairly constant over calendar time. Next slide. And when we look at VE against hospitalization, it was also constant when analyzed as time since vaccination. As seen here in red, Jansen vaccine effectiveness was lower than that observed for mRNA vaccines. Next slide. So in summary, more than 189 million people in the US are fully vaccinated. That's approximately 57% of the total population. Hospitalization rates are 9 to 15 times higher in unvaccinated as compared to fully vaccinated adults. The Mrna primary vaccine series has been used to vaccinate about 37% of those fully vaccinated. It appears to decline against infection over time and during the Delta period. On the other hand, there have been minimal to no declines in VE against hospitalization in younger adults and mild declines observed in some study platforms among older adults. Approximately 8% of fully vaccinated people received the Jansen COVID-19 vaccine. This vaccine shows lower VE compared to mRNA vaccines. However, study platforms show persistent VE over time against infection and hospitalization, even among older adults. Next slide. And now to review the evidence for benefits and harms of Mrna and Jansen COVID-19 boosters. Next slide. So the Pico question used for grading were as follows. Note that in order to assess all the available evidence, we examined adults 18 years of age and older for both vaccines. The Mrna booster of 50 micrograms, or a half dose, at least, or 6 months or more following the primary regime, and Jansen booster dose at 2 months or more following the primary regime. For both vaccines, we attempted to compare the effects of the booster to those who received the primary series but no booster. As for the outcomes, those were consistent with those assessed for the Pfizer booster doses. Next slide. The evidence retrieval for Jansen booster doses yielded 2 clinical trial records and no observational vaccine effectiveness studies. Similarly, evidence retrieval for Mrna booster dose as intervention yielded 2 clinical trial records and no observational vaccine effectiveness studies. Those studies were explained in detail by representatives from Mrna and Jansen earlier this morning, and I'll summarize them again here. Next slide. So Moderna's data for immunogenicity of a 50 microgram booster following the primary series of 100 micrograms comes from a study of 149 subjects. A larger group with immunogenicity data available following the primary series was used as a comparison group. At 28 days following the booster dose, neutralizing antibody titers were 1.8 times those in the comparison group, thus meeting the pre-specified endpoint for non-inferiority. However, no clinical outcomes were assessed, and participants were not randomized to the intervention or comparison group. Therefore, the evidence type to assess the prevention of symptomatic COVID was type 4, or very low certainty. There was no data available to assess prevention of hospitalization, death, or transmission of SARS-CoV-2. With respect to possible harms, no serious adverse events were attributed to the 171 subjects assessed for safety of a Mrna COVID booster at 50 micrograms. The proportion with any serious adverse event was balanced between the intervention and the comparison arm. In terms of reactogenicity, 10.8% of the 50 microgram booster group experienced a grade 3 or more severe reaction, compared to 19.7% of the 100 microgram primary series comparison group. Certainty for both of these harms outcomes was downgraded as a result of study design, risk of bias, and small study size. Both were judged to be type 4 evidence. Next slide. Now for the summary of the grading of Jansen. Jansen's evidence for use of a booster dose was primarily generated from a clinical trial where subjects were randomized to receive 2 doses of Jansen vaccine 56 days apart versus placebo. Wherever possible, we tried to compare the effects of the booster dose administered to approximately 7,484 participants to a primary dose administered to over 19,000 participants in their initial clinical trial. Jansen COVID-19 booster dose seems to be more effective at preventing symptomatic laboratory-confirmed COVID-19 than the primary dose alone. However, because participants were not randomized to the intervention and comparison groups, and results were compared across 2 separate studies that differed in time and geography, the evidence type was low, type 4. The Jansen booster dose may be more effective than the primary dose at preventing hospitalizations and deaths due to COVID. But because of concerns with study design, risk of bias from considerable dropout, and imprecision resulting from small numbers of outcomes, the evidence type for both was type 4. There was no data to assess the prevention of transmission. For serious adverse events, over 8,000 participants who received the Jansen booster dose were compared to placebo recipients. The proportion with any serious adverse events was balanced between the booster and the placebo arms. However, 3 serious adverse events were attributed to the Jansen COVID booster dose by study staff. Those were facial paralysis, pulmonary embolism, and cerebrovascular event. With respect to reactogenicity, the proportion with grade 3 reaction or a more severe reaction following a booster was similar to or less than after the primary dose. Because of loss to follow-up, short duration of follow-up, indirect comparison, and imprecision, the evidence was type 4, or low certainty, for both harms that were assessed. Next slide. Another way to assess benefit of a booster dose is the number of people needed to vaccinate with a booster dose to prevent one hospitalization. Presented here for Pfizer, Mrna, and Jansen COVID-19 vaccine booster doses. The analysis is based on current estimates of VE following the primary series and the estimated increase in protection resulting from a booster. The 65-year-old and older age group requires the fewest people to receive a booster dose to prevent a hospitalization, whereas younger adults require more people to be vaccinated with a booster to prevent a hospitalization. Next slide. So large-scale and rigorous post-authorization safety surveillance has identified safety issues that may be too rare to see in standard clinical trials. As discussed in detail in the safety presentations earlier today, myocarditis and pericarditis have been observed following Mrna COVID-19 primary series. This has been noted and included in the EUA fact sheet. The risk is noted to be particularly high within 7 days following the second dose and is highest among males under 40. Although most cases resolve, the long-term sequelae are not fully understood. The highest reporting rate is in 18 to 24-year-old males in the 7 days following dose 2 and has been reported at 39 cases per 1 million doses administered. Next slide. So thrombosis with thrombocytopenia syndrome, or TTS for short, has been identified following Jansen primary vaccination. TTS, of course, involves blood clots with a low level of platelets and has been reported in its highest rates in females aged 18 to 49. The highest reporting rate is in 30 to 39-year-old females in the 21 days post-dose and reported at 10 cases per 1 million doses administered. Next slide. And finally, Guillain-Barre Syndrome, or GBS, has been identified following Jansen. The highest reporting rate is seen in 50 to 64-year-old males and has been reported at 16 cases per 1 million doses administered. Next slide. So as you saw in the presentation provided by Dr. Atmar this morning, heterologous boosting, also known as mix and match, could provide important immune benefits as well as enhance feasibility of implementation of a booster dose program. To recap, this NIH-sponsored study showed that use of Mrna, Jansen, and Pfizer-BioNTech COVID-19 vaccines as boosters led to strong serologic responses in groups primed by all three of those vaccines. For a given primary COVID-19 vaccine, heterologous boosts elicited similar or higher serologic responses as compared to their respective homologous boosting responses. mRNA vaccines resulted in higher antibody titers in the first 28 days after the boost. Although the study arms were small, involving somewhere between 49 to 53 subjects, no safety concerns were identified. Next slide. And now to look at values and acceptabilities with regard to booster doses. Next slide. In published studies completed in August before the recommendation for booster doses, 76 to 87% of vaccinated adults reported that they would get a booster dose if available. In fact, in one survey, this increased to 93% of surveyed adults if the booster was recommended by their primary care provider. Next slide. And now we actually have data to indicate how many people have received a booster or additional dose so far. So prior to booster doses being recommended on September 23rd, approximately 3 million additional doses had been administered, presumably mostly to immunocompromised individuals. Following the booster dose recommendation, the total number of booster or additional doses has increased to approximately 10.9 million. The vast majority of booster doses have been administered to people 65 years of age and older. Next slide. Now let's discuss the feasibility and implementation of boosters. Next slide. So this is a figure of the number of people who completed their primary vaccination regime over time. Pfizer vaccine recipients in gray, Mrna in orange, and Jansen in blue. Next. For all three vaccines, most people completed their primary vaccine regime did so more than 6 months ago. Next slide. And here's a detailed breakdown of the number of people either 6 months post their mRNA primary series or 2 months post the initial dose. For Jansen, that's 12.9 people, and for Mrna, almost 18 million people over the age of 65, as well as 21 million younger people, a portion of whom would be recommended to receive a booster dose. Next slide. Implementation of the booster dose within long-term care facilities has already begun. In CDC's federal pharmacy program provides vaccination support to long-term care settings, including on-site vaccination clinics where needed, and also help to residents access vaccine in the local community. 8.1 million doses were administered during the long-term care facility program rollout, which occurred in December 2020 to March 2021. That was 6.2 or 76% Pfizer-BioNTech, and 1.9 million or 24% were Mrna in that initial rollout. Thus far, the program's support for booster doses has been restricted to Pfizer-BioNTech recipients based on current FDA and CDC guidance, thus leaving anybody who initially received Mrna or Jansen unable to participate in this long-term care facility program. Next slide. And now for resource use. Next slide. All COVID-19 vaccines, including booster doses, will be provided free of charge to the U.S. population. Of course, although free to the end user, health systems or health departments incur costs for vaccination program planning and implementation. And fees for administration of COVID-19 vaccines recommended by ACIP and CDC are reimbursed by insurance and other federal programs. Ultimately, cost-effective analysis for COVID-19 vaccines will take on increased importance in the future when the public health emergency is over. Next slide. And now for the domain of equity. Next slide. So the following graph shows the percentage of booster dose administration by race ethnicity. The data is shown for the 9.8 million people with a booster or additional dose administration whose race ethnicity was known. That's about 90% of all the additional dose or booster doses that have been administered since August 13th. The group percentages of booster doses is in blue bars, and the group percentage of the U.S. population is in green bars. Both Black, non-Hispanic, and Hispanic Latino groups comprise a lower share of booster dose recipients compared to their fraction of the U.S. population. It should be noted that these data are not age standardized. Next slide. It's important to note that while COVID-19 disease and COVID-19 vaccination varies by socioeconomic and sociodemographic groups, vaccine effectiveness, on the other hand, does not vary by race, ethnicity, or economic variables. At present, only recipients of Pfizer-BioNTech COVID-19 vaccine primary series have been recommended to receive a booster, thus creating an inequity for recipients of Mrna or Jansen. Moreover, Jansen COVID-19 vaccine may have been used more commonly for outreach to homeless or medically underserved communities because it is a single-dose regime. Next slide. In summary, next slide. The work group maintained that the top priority should be to continue vaccination of unvaccinated individuals. The goals of a booster program should be the prevention of severe disease, including hospitalization and death. However, other considerations are important, such as maintaining workforce and healthcare capacity, prevention of transmission, as well as considering individual benefit and risk balance. The balance of benefits and risks varies by age. For example, adults 65 years of age and older have the clearest benefits over risks. For Mrna vaccine, benefits are incrementally smaller with decreasing age, given the high effectiveness maintained for the primary series. Also, myocarditis risk is higher among young adults. For Jansen, the benefits may be smaller across all age groups compared with mRNA vaccines. TTS risk is higher among young females. Next slide. The work group also considered that for people who received Mrna COVID-19 vaccine as a primary series, the work group supported using a single booster dose at 6 or more months following the primary series in certain populations. In other words, those consistent with CDC recommended populations for Pfizer-BioNTech COVID-19 booster. For people who received Jansen COVID-19 vaccine as a primary vaccination, the work group supports using a single booster 2 or more months following the initial dose in all people aged 18 years of age and older. A single dose of Jansen COVID-19 vaccine results in lower VE and antibody levels compared to mRNA vaccine primary series. Data demonstrate that a single dose of Jansen or mRNA COVID-19 vaccine boost immune responses in these individuals. Next slide. I'd like to acknowledge the many people who made this presentation possible. Next slide. And now I'd like to turn it back to Dr. Lee.
Thank you very much, Dr. Dooling. We can open this presentation for what I'll call a few clarifying questions, but I just want to acknowledge the rest of the session, which is we have Dr. Reddy who will present on clinical considerations that might impact some of the questions you might have. So I want to make sure that people are aware of that. And in addition, we need to have the full policy discussion. I'm hoping we can have that policy discussion together, but I wanted to open it up in case there are any questions on Dr. Dooling's evidence to recommendation framework. Dr. Chen.
So, and maybe this will be brought up in the clinical considerations discussion portion, but I'm thinking specifically for international folks who might have come and have received a WHO pre-qualified vaccine. And will there be, well, we haven't seen data, certainly, but will there be the allowance, the latitude within the clinical considerations for these people receiving a booster dose? Because again, for the current language for the Pfizer is, of course, they must have received the Pfizer primary series. So I'm going back to maybe some of the discussion with mix and match, but also to WHO pre-qualified vaccines or international vaccines that we don't have in the U.S. And there may be many people throughout the U.S. that again are wondering if when they can receive a booster dose.
Thank you for that question, and that is under active consideration here, and certainly will be part of the clinical considerations. Perhaps not fully hammered out yet, but we can give an indication on what information we have available so far later in the clinical considerations talk.
Thank you. Dr. Sanchez.
Yeah, just a clarification of that as well. So we will not be voting or making any recommendation for a mix and match. That will only be considered under clinical consideration.
You know, as per usual, we will have our full vote discussion, and I'm thinking maybe perhaps we should go on to the clinical consideration so you can see the totality of the information presented, and then we can talk about sort of what goes in the vote and what's in clinical considerations. If that's okay, Dr. Sanchez. And I also just want to acknowledge, Dr. Chen, that, you know, your question is an important one that's very pragmatic, and I am sure we're going to have a fuller discussion on this, but I just would like Dr. Reddy to present, if that's okay.
That's fine with me. Great. Thank you.
All right, let's go ahead then and see where this takes us. Dr. Reddy.
All right, sounds good. Thanks. I'll be reviewing the updates to the interim clinical considerations for Moderna and Jansen COVID-19 vaccine booster doses. Next. Here's a brief outline of what I'll be discussing. I'll talk about the indications for vaccine boosters, and I will be talking about heterologous booster dosing, also known as mix and match boosting dosing, as well as booster administration, the definition of fully vaccinated, and other aspects like co-administration of other vaccines, contraindications, and precautions. Next slide. So Dr. Dooling also mentioned this, but it's worth mentioning again. The indications for a booster dose following mRNA COVID-19 primary series would be the same for Pfizer, BioNTech, and Moderna vaccines. The following groups who received mRNA primary series should receive a single mRNA COVID-19 booster at least 6 months after completion from their primary series. These groups include people over the age of 65, people over the age of 18 who reside in a long-term care facility, and people who are 50 to 64 years old with certain underlying medical conditions. The following groups who received an mRNA primary series may receive a single mRNA COVID-19 booster dose at least 6 months after completion of their primary series based on their individual risks and benefits. These groups include people aged 18 to 49 with certain underlying medical conditions, people aged 18 to 64 who are at risk of SARS-CoV-2 exposure and transmission because of their occupational or institutional settings. Note these are slightly different from what the FDA announced yesterday as well. In general, the same product that was used for the primary regimen should be used for the booster dose. Next slide. As a reminder, for the category of people who, quote, may receive an mRNA booster, we recommend an individual risk-benefit assessment considering factors such as the following. Does the person have increased risk for SARS-CoV-2 infection? That may come from an increased risk to exposures from their occupational or institutional exposures, or it could also be an increased risk related to other factors, such as the time since they completed their primary series due to waning immunity. If the individual were to be infected, they may want to consider what impact the virus could have on themselves as well as those around them. Individuals with underlying medical conditions are at increased risk for severe infection. But also importantly, people may want to consider their personal circumstances, such as are they living with or caring for people that are at risk? Or maybe they want to consider how a non-severe infection may affect their ability to meet their other obligations, such as work, due to their infection. The person also may want to consider the benefits of the booster shots. As discussed today, the boosters are likely to reduce their infectious risk, including the risk for severe infection. Lastly, a person may consider the potential risks, including the rare risks of mRNA booster doses, such as myocarditis and pericarditis, as well as consider the common risks of transient local and systemic symptoms. Next slide, please. For people who received a Jansen primary dose, the indications for boosters is much simpler. All people aged greater than 18 who received a single dose of Jansen primary series should receive a single Jansen COVID-19 booster dose at least 2 months after completing their primary series. Next slide. Now, let's talk through heterologous booster dosing, also known as mix and match booster doses. The same product that was used for the primary regimen should be used for the booster dose. However, if that product is not available or another product is preferred, heterologous boosting with a single dose of any authorized or approved COVID-19 vaccine booster is acceptable. Heterologous dosing may be considered only for the booster dose. So for all primary doses and additional doses for immunocompromised people, they should receive the same vaccine product. As a reminder, the additional doses are only for those that have moderately to severe immunocompromised who have already received 2 doses of an mRNA vaccine. I think a common question may be, which product should we use? As we stated, we would recommend trying to use the same product as a primary series, but people may consider heterologous dosing based on the availability of the product as well as the risk profile of the vaccine boosters, including rare events. Next slide. I wanted to mention a few additional considerations related to heterologous booster doses. The interval between primary dose and the booster dose should follow the interval recommended by the primary series that was used. So for instance, people who received a single dose Jansen primary series can receive an mRNA booster dose at least 2 months after completing their primary series. It's important to note that if a Mrna booster is used, the booster dose and volume is 50 micrograms in 0.25 milliliters, which is half the dose that's used in primary and additional doses for Mrna. I would note also that the dosing for Pfizer-BioNTech and the Janssen boosters are the same as the primary vaccine products. If an individual is moderately to severely immunocompromised and received a primary dose of Janssen vaccine, and they are going to receive a Mrna booster, I wanted to note that they should be receiving a half dose of Mrna, which is the 50 microgram dose. Next slide. Okay, so I wanted to lay out where we stand in terms of dosing, number of doses recommended, and the age recommendations for the primary series, additional doses, and the booster dose. The Pfizer-BioNTech recommendations are unchanged for primary, additional, and booster doses. As mentioned, the dose is the same, and I would say this is for ages over 18. Obviously, in future weeks, that will have to likely change. For Mrna, as you can see, the booster dose is half the dose, while the additional dose is the 100 microgram dose. As for Janssen, we wouldn't be saying that immunocompromised people are getting, quote, an additional dose. Rather, they, like everyone else over the age of 18 who received Janssen, would be getting a booster dose at least 2 months from their initial. As explained in this footnote and on the previous slide, the interval stated here is the booster dose assuming homologous dosing. Next. Now, I wanted to move on to other considerations related to this booster regimen. The definition of fully vaccinated has not changed with these booster recommendations. People who completed their primary series, which is a 2-dose mRNA vaccine series or a single dose of Janssen, are considered fully vaccinated at least 2 weeks after 2 weeks after completion of their primary series. This definition applies to all people, including those who recommended to receive an additional dose due to their immunocompromised state and those who are recommended for a booster dose. People who received a booster dose should still follow guidelines for fully vaccinated people to minimize the spread of SARS-CoV-2. Next slide. Given we are ramping up influenza vaccination, we wanted to reiterate points on co-administration with other vaccines. The COVID-19 vaccine boosters, similar to primary and additional doses, may be given with other vaccines without regard to timing. This includes all 3 of the authorized or approved vaccines. This also includes simultaneous administration of COVID-19 vaccines and other vaccines on the same day. If multiple vaccines are administered at a single visit, we would recommend administering each injection in a different injection site. Next slide. I wanted to remind people of the contraindications to booster doses related to allergy. People have a contraindication to subsequent vaccine doses if they had a severe allergic reaction, such as anaphylaxis, after a previous dose or to a component of the vaccine. People also have a contraindication if they have an immediate allergic reaction of any severity to a previous dose or a known diagnosed allergy to a component of the vaccine. I would also want to note that people who have a known polysorbate allergy is a contraindication to the Janssen vaccine. As a reminder, if you have a contraindication to one vaccine product, you have a precaution to the other vaccine products. So for people who have a contraindication to mRNA vaccines, such as those that have a PEG allergy, they would have a precaution to the Janssen vaccine. Next. Briefly, I just wanted to say that we have additional tools available for recognizing anaphylaxis at the link below. Next. Now, there are potential rare risks as discussed for mRNA vaccines, such as myocarditis and pericarditis. The risk of myocarditis and pericarditis is highest in males aged 12 to 30, but this is based on current data from primary series, which we just saw. For people who develop myocarditis or pericarditis after mRNA vaccine, we would recommend deferring COVID-19 booster until at least the clinical syndrome has resolved. We also think consulting the clinical team may assist with decisions around proceeding with subsequent doses and the timing of that dose. Next slide. For the Jansen booster dose, there is a rare risk for thrombosis with thrombocytopenia syndrome, also known as TTS. Based on what we observed with the primary series, the highest risk group are women aged 18 to 49. For people who develop TTS after Janssen primary vaccine, a booster dose of Janssen is not recommended by experts. These individuals may receive a dose of an mRNA booster shot at least 2 months after their Janssen dose and after the clinical condition has stabilized. And again, conversations between the patient and their clinical team may inform these decisions. Next slide. Guillain-Barre Syndrome, or GBS, is another known rare risk of Janssen vaccines. For people who develop GBS after Janssen primary vaccine, we do not really have a lot of data on the safety of administering either the Janssen or mRNA booster doses for this exact situation. Experts recommend that individuals who are in this situation should be made aware of their different options, including receiving an mRNA vaccine booster at least 2 months from their Janssen dose. The Janssen vaccine may be utilized as a booster in these individuals, particularly if their GBS occurred over 42 days after vaccination or was assessed to be related to a non-vaccine factor such as other infections. And as before, discussing with the clinical team may assist with these decisions. Next slide. As always, we continue to update many of these clinical considerations for COVID-19 vaccines with the help of all these people listed on this slide. So thank you.
Thank you, Dr. Reddy. Are there any clarifying questions that are specific to the clinical considerations that people would like to bring up? And also just recognize that we can also do this after we discuss the full vote. Ms. McNally.
Thank you. For the immunocompromised people who receive J&J, is it now going to be recommended, I just want to make sure I understand, that they receive J&J as opposed to an mRNA vaccine?
So the way that we're approaching, and we're open for a discussion on this, is that we would recommend that they should get the same homologous dose as what they got their first dose. So in that case, they would get Janssen. But there could be situations based off of their preference or product availability that they would be able to get an mRNA vaccine.
So, Ms. Minelli, this is Amanda. I just want to add, I think for these immunocompromised groups specifically, we're hoping that this is a clinical decision that the provider makes with the patient to clarify an individual who we believe that the number of individuals who received a Janssen vaccine who are immunocompromised is likely very low, but they likely exist. And the overall recommendation will indicate what we're talking about in terms of voting, but there would be sort of additional preference for individuals who have these types of questions to talk to their providers. I'll also just say as we open this up for discussion, these are the votes that we're proposing. Kathleen will discuss the policies that we're proposing and the votes that we're considering, but these can be adapted as we did yesterday if you guys have a preference to edit the language. Thanks.
Thank you. Dr. Lee, I have a couple more questions. Would you let me know when it would be appropriate to ask those?
Yes, just hang on a sec. I just want to clarify. It relates to this slide, which I also actually had very similar questions on, and whether or not, and the description you just gave, Dr. Reddy, I just want to make sure I understand the description, which is essentially the bottom two right boxes look the same. So I wonder if we can just, I think I got thrown off, and now I see the C booster dose. At first I missed that. So I'm just wondering if it can just contain both those together.
I think that's a good point, and kind of similar to what was discussed. I think the intent is that if a person who had a Janssen primary series and they're immunocompromised, the question is which is the appropriate mRNA booster dosage to give them. We would want to try to indicate it would be the 0.5 microgram, sorry, the 50 microgram dose, unless other people have discussions about it for Moderna, if it's a Moderna dose, exactly.
Or a 30 for the
Pfizer, exactly.
Okay. All right. Yes, I think that would be incredibly helpful. And just perhaps, I think it would be really helpful for all of us if we were clear on what is an additional dose versus what is a booster dose. I recognize that this is, to a certain extent.
We can't hear.
Sorry. This is the second time in 2 days I've done that. Okay. I wanted to thank Dr. Reddy because I think that makes a lot of sense. The other thing I wanted to comment on was that I do think we need clarity when speaking to the public about the difference between an additional dose and a booster dose, because I think it is very confusing. I recognize that we sometimes are using them in overlapping fashion because of the way the regulatory language exists, and but it doesn't necessarily speak to intent. And I feel like the public really needs to understand the intent of the dose and what the purpose is. And so if there's possibility of clarifying that language in some way, I think it would be useful to all of us. Ms. McNally, you had a few more questions. Please go ahead.
Thank you. We heard a little bit about the challenges with registries and the Moderna booster dose, but what additional challenges, if any, exist as it relates to the J&J booster dosing? Thank you.
So, Ms. McNally, I think what you're asking is, so if a person who received either a Jansen or a Pfizer primary series chooses to get a Moderna booster, they would regardless be recommended to get the 50 microgram dose. So it would be the same monitoring challenges in which that would exist than if they got the primary series as Moderna. Is that your question?
Yes. But otherwise, the registries are set up to accept booster doses, right? Mm-hmm. There's no issue with tracking, other than what we've identified.
Yeah, the booster dose won't be a problem in terms of the registries identifying a booster or a third dose or a second dose, an additional dose, whichever word the registries would use. I think the challenge in the registries is capturing the amount of Moderna product that was received, the volume, in terms of it being 0.25 cc's versus 0.5 cc's. So while you may know that it's an individual's third dose, you may not know the dosage that they got.
I just want to ask Ms. Coyle, if you're on, would you add any comments to that?
Okay. Sure, thank you. This is Rebecca Coyle, and I'm happy to provide some context. I think the reason why we brought up the issue with the Moderna doses are that the packaging is one package for full dose and same package for the half dose. So because systems are set up, and it's not exclusive to immunization registries, it includes a variety of other systems that are used for tracking. So pharmacy systems, EHRs, their inventory management systems are set up to be able to draw down and account for those doses. I think the difference this time versus other pandemics and other situations are that there's an increased accountability of vaccines and making sure we know where every dose is going and to whom they're receiving it. In the situation where we can't distinguish between a half dose and a full dose, with Moderna, that presents some challenges for record keeping. I think we're all aware of the situation, and I think we're all maybe not thrilled with how this is going to roll out, but we understand that. I think going forward, as Moderna goes for licensure, full licensure, we would greatly appreciate the differentiation between a half dose and a booster dose in the packaging, thus new NDC codes and CVX codes. Thank you.
Thank you, Ms. Coyle. And just as with everything in the pandemic, we're just going to have to continue to adapt and learn as we go. So, Ms. McNally, you had one more question?
Yes, I think it would be helpful to hear whether or not there's been any issues identified on safety concerns in co-administration since we have permitted the co-administration for several months now.
I believe that was somewhat covered. I just want to confirm, and if Dr. Shimabukuro is still on the line, or Dr. Su or Dr. Klein, if any of them would like to comment, please feel free to chime in.
Hey, this is Dr. Shimabukuro. The data are pretty limited. I mean, usually the COVID vaccines are given alone, but we do have some co-administration, and we are able to monitor that in VAERS. We have some work ongoing in VSD as well, and we can capture that generally and be safe, and we're working to capture it specifically. And I think that'll be important as we start to vaccinate children. So the data we have so far does not show any indication of a safety problem with co-administration with other vaccines, and we'll continue to monitor and update ACIP as we gather more data.
Thank you.
Thank you. All very helpful.
Thank you. We'll move on to Dr. Sanchez.
Thank you. Actually, with respect with the co-administration, Tom, I would just also reiterate what I said previously with the smallpox vaccine. If you can, because there should be some comments. I know it's rare and it's only given military in very unusual circumstances, but that has come up in our work group, and I think that should be addressed as a possible not co-administration at the same time. Yeah.
Dr. Sanchez, can you just elaborate on that?
Yeah, because the ACAM 2000 has been associated with pericarditis, and so there has been some concern about whether the messenger RNA vaccine should be given at the same time as for instance, the ACAM 2000. And I know that in some instances it's being delayed. So I just think that some comment about that should be made.
Yeah. And Dr. Sanchez, this is Amanda. I just want to remind everyone that ACAM 2000 is pretty much only used right now in the military population. We will take that into consideration and think about the right way to address that. But that's a good point. Thank you.
I agree. It's a rare situation, but as we make recommendations, it'd be nice to just mention it. My question regarding this is that I'm glad that one dose of the Jansen product is still being considered as a primary series, because it'll give us or give individuals leeway to consider the messenger RNA vaccines as for booster dosing, because I remain very concerned still about a second dose of the Janssen product for reasons that I've mentioned previously. Thank you.
Thank you, Dr. Sanchez. Dr. Daly?
Yeah, thanks so much. And Dr. Reddy, thanks for these clinical considerations. I mean, I think, we have these challenging decisions to face, but then we have these challenging communication issues to face too. Could you go to the slide where you talk about recommendations for boosters and considerations for heterologous vaccination? I'm sorry that I didn't write down what slide number that was, but. Yeah, this is it. So was there any consideration in individual benefit risk assessment of discussion of what appears to be higher immunogenicity when an mRNA vaccine is used as a booster dose? Or was the consideration there that there's just not quite enough data to make that strong of a statement here in terms of individual benefit risk assessment?
I think that's a great point, and yeah, we've been discussing that. I appreciate input from the group as well, whether to cite the NIH study in this section and word it appropriately that those are immediate antibody responses that were assessed in that particular study. But I think that's a fair point to potentially bring up in the risk-benefit assessment.
Okay, thank you. We'll move on to Dr. Talbot.
I have two clarifying questions. The first is there any way that we can drop that that the same product should be used for the primary regimen for the booster? I guess we have the data from the NIH, which is small, but there's also data out of Europe that mixes adeno and messenger RNA, and so there is good data. So thinking that if you only open like one messenger RNA instead of two, and you use that one up instead of us having two bottles open and throwing stuff away, it just seems like a reasonable thing. So I was just wondering if this is a requirement from the FDA that we have to say that's the preference, or is this something we just can get rid of?
Dr. Talbot, this is Amanda. This is the language that we're putting in front of you for feedback, and I think that we're hearing some feedback about y'all's about the committee's considerations on whether or not we prefer homologous or we allow for anything. And so I think we can adapt, and I think once Kathleen puts up the policy votes, we can also discuss that topic then. So thanks.
I just didn't want to make sure this was one of those FDA, bumpers that we had to bounce within.
Yeah.
Okay.
So
and then my second question.
Oh, so the FDA bumpers for the EUA as it's phrased now allow for heterologous use. I think if we had a preference for heterologous use, that would be outside the intent of the FDA, but allowing for it is acceptable.
And then I'm going to disagree a little bit with Dr. Sanchez. I would prefer that the J&J be a 2-dose series, and was wondering if that's an FDA bumper or not. Thank you.
So,
This is Doran Fink. So at this time, under emergency use authorization, the Jansen COVID-19 vaccine is authorized for use as a single-dose primary vaccination and also as a single booster dose. This is not determinative of what the vaccination regimen might ultimately be as we accrue additional data. But at this time, it's authorized as a single-dose primary vaccination. Thank you.
Thank you, Dr. Fink. Thank you for jumping in.
Grace, can I respond? This is Pablo Sanchez.
Oh, sure. Sorry, I missed your response hand.
Okay. No, sorry. No, with respect to Dr. Talbot's comment, I agree that those who received a single dose of the Janssen product should get a second dose of a COVID-19 vaccine. I'm glad that it says primary series, because in terms of the mix and match wording, I would prefer then that those individuals get a messenger RNA vaccine, not because I don't think that they should get 2 doses of a vaccine, just to clarify.
I think we're on the same page. We just said it differently. Thank
Understood.
You.
Thank you both. I'll move to Ms. Bata.
Sorry, I saw so many other hands up. I wasn't expecting to jump in here. I too would support what Dr. Talbot was saying to soften the language about the same product, knowing how detailed some of our vaccinators can be. They would take this more as the law rather than the flexibility. And I think we need to really make this as flexible as possible. And then I'm still wondering about, and I don't know what slide it is, the one that you had raised, Dr. Lee, about the mix and match chart. And with the Janssen, the additional dose in immunocompromised, the suggestion if it's going to be it says see booster dose for those in immunocompromised, and I don't understand why that would be a booster dose if it's considered an additional dose, not boosting. I think the purpose of additional doses is to try to ensure that the person might respond to the actual series. And I don't understand why we would, if they were going to mix it with Moderna, they would drop to a booster dose.
Yeah, I appreciate the questions about this. I think what we might try to do is maybe clarify this slide a little bit more in the table that's being shown right now to make it more clear of what the intent is. But I think we hear your comments.
Thank you.
Dr. Sanchez, did you want to respond again?
No, but I have comments. I have another one, but that's no. Can I ask a question now?
Yes, go ahead.
Sorry. No, I just also want to echo or again state that I would prefer a more permissive use of mix and match in the recommendations as well.
Thank you. We're definitely hearing some consistent remarks, even though we might be using slightly different language. I'll turn it over to Dr. Kimberlin.
Thank you, David Kimberlin, AAP Red Book. Could you go to slide 7, please? I believe this is going to be a bit redundant based on what's already been asked, but the final sub-bullet, if an individual who is moderately to severely immunocompromised received a primary dose of the Janssen vaccine and receives a booster dose using Moderna, the 50 microgram dose should be used. Can you confirm that someone who is not moderately or severely immunocompromised who received the primary dose of Janssen should also receive that same booster dose of Moderna at 50 micrograms if they're getting Moderna as the booster?
So, Dr. Kimberlin, this is meant to say that this is, yes, of course, everybody who is getting a Moderna booster should get a 50 microgram dose. The difference is that in individuals who received an mRNA primary series who are moderately to severely immunocompromised, they would be getting that 100 microgram dose of Moderna if they choose to get Moderna. However, under the EUA, if you get the Janssen as your first dose and you're immunocompromised, you would need to get the 50 microgram dose, or you could choose to get the Pfizer vaccine.
All right, thank you.
Thank you. Dr. Dries?
Yes, thank you. I also have a question about the table on slide 8, I think. So similarly, with immunocompromised patients, if they initially got the Pfizer or Moderna primary series and then got a third dose of the mRNA vaccine, do they then also get the booster dose 6 months after their third dose? Right now, that's not the current recommendation, but it makes sense if that third dose is considered their primary series, that they would still qualify for a booster.
Yeah, that's a great question. We will clarify this in the document itself. I meant to mention this, but at the moment, the maximum number of doses someone can receive for an mRNA vaccine would be 3. So if they got a 2-dose primary series plus an additional dose, at this time, we have no recommendation of whether they should get a booster dose.
Okay, thank you.
Thank you. Dr. Fink, you raised your hand. Did you want to respond specifically?
I don't know if this will be helpful or more confusing, but the allowance under EUA is that a third dose administered to individuals with certain types of immunocompromise, that counts as a third primary series dose. And eligible populations for a booster dose following primary series with mRNA vaccine include anyone who is 6 months out from completion of a primary series who falls into the specified eligible populations. So under the EUA, someone who is immunocompromised and receives a third primary series dose would 6 months later be eligible for a booster dose.
Thank you. Yeah, I think, the other part of this is that we should keep in mind is, those additional dose recommendations just went out a month or two ago. And so people aren't really eligible for that booster dose at the moment, potentially. And so we do want to continue to have this kind of conversation to clarify this issue in the appropriate timeline.
Thank you, Dr. Reddy and Dr. Fink, for those clarifications. And we will move on to Dr. Cotton.
Thank you. I would just like to advocate for flexibility with the mix and match approach, in that I think it would help with equity. As a clinician in the field, I am seeing people who are quite savvy, able to read the medical literature, and they seem to be advocating for some of the more robust approaches to booster vaccines. And for equity purposes, I would really like to allow better flexibility so that clinicians in the field can more easily adapt and serve the populations that they take care of as they see fit. Thank you.
Thanks. We definitely hear that, and we'll be thoughtful of that as we try to word it appropriately of who's preparing things. Thanks.
Thank you. I'm going to go to Dr. Long next.
Yes, thanks, Dr. Lee. I'm bothered by several things. One is that we continue to say that our decision should be supported by the best available evidence. And yet, what available evidence is there that people under the age of 50 should receive a booster at this point? We're setting aside Jansen. That's a special, and we could argue whether that's a booster or not. They've not had waning. They just need a reinforcing dose. But I just feel that we're abdicating our responsibility not only to allow people to be immunized if they should be immunized, but to protect them from immunizations that they do not need that have adverse events. So I am still very much bothered by the category of the 18 through 64 with perceived increased exposure. And I'm especially uncomfortable with it if we think that really is healthcare workers and frontline workers, because healthcare workers do not have increased exposure from their work. We spend, $1 billion to keep them protected. And the data would suggest that they're more likely to get their exposure from non-work situations. I'm also very concerned that these are not individuals who have increased risk of severe disease. There are many more individuals who are not healthcare workers, who are not frontline workers, who do have increased of severe disease if they should be reinfected and get severe disease because they have had waning. So I think that the last decision was made in this regard was not a correct decision, and we're somewhat stuck with it, but I can't say that I am comfortable that anybody under 50 needs otherwise healthy individual needs a booster vaccine at this time with either Mrna or Pfizer, and that we then take the trust of the system and the trust of the safety, and we are playing with it with concerns that there could be harm. So I would try to mitigate the harm by having some age restriction on the otherwise worried well, because we don't usually give vaccines because we have the worried well. We give it because there's a need that's worth the risk and there's the burden of severity of disease. So that's my little piece for today.
Thank you, Dr. Long. We're going to park that for a moment because I would like to, reserve that continued discussion for later. I just want to make sure that of the speakers' hands that are raised, or the questioners' hands that are raised, that this is going to focus on the clinical consideration so we can move on to the full discussion. Dr. Sanchez.
Thank you. I just wanted to comment on the indications for booster. And this came up before. I know with the group who may receive the RNA booster dose, one of them in clarification is that individuals living with or caring for at-risk individuals. And I certainly agree with that. However, I don't think that's clearly stated in the indications. Whether it's sufficient to just put it as a clarification, I guess that's fine. But I really think that should be included. This came up also with the previous Pfizer recommendations. And then I just want to really re-echo Dr. Long's comment. So when you see here, the risk associated with person's circumstances living with or caring for at-risk individuals, if you go to the previous slide, can you go to the previous slide? Age 16 to 64 at increased risk for SARS-CoV-2 exposure and transmission because of occupational or institutional setting. That really, I don't think that covers that. And I think should be included in there.
Thanks. Yeah, I think I understand your comment here. That those are important factors about who they may be exposing when they get infected, and we will definitely think through that as we try to make this more clear in the document.
Thank you. And I'll just maybe make a really brief comment, which is when I read this initially, specifically around occupational institutional setting, I was thinking honestly about sort of workforce issues where we were really having challenges with staffing and needing to actually start to triage care, even the routine care that we give to patients, because of capacity issues that we were seeing in some regions of our country. And so being able to allow for flexibility in my mind made sense, and even reducing the risk of infection and missed days of work makes a huge difference. We really truly are very dependent, especially on our nursing workforce. And so for whatever that's worth. And then the other thing I'll just comment on that we haven't talked about more explicitly, but I do think it's worth raising, is that in some congregate settings, and I would highlight, for example, people who are incarcerated, they might be at risk for infection because of the setting that they're in, and there have been outbreaks that have occurred. And so being able to offer, and this is not a requirement, but offer that protection, may be of benefit in certain settings. I'm just expressing my opinion, but I'm going to go on to Dr. Daly.
Yeah, thanks very much, Dr. Lee. I wanted to respond directly to Dr. Long's comments because I've been thinking quite a bit about what she raised, and I've been trying to think about how do we best minimize risk, and by that I mean vaccine-associated risk. And is it best done through clinical considerations, or is it best done through a vote on age groups, for example? And I don't know that. I honestly don't know. I think the one factor there is that I think that the vote language is kind of front page news, and the clinical considerations are often sort of they don't receive as much attention. Although I think vaccinators should pay really close attention to the clinical considerations. But Dr. Long, I'm trying to think about whether more explicit language within clinical considerations about different vaccine choices can potentially mitigate vaccine-associated risk, such as highlighting that there's rare but serious adverse events following Janssen vaccination among women 18 to 39, for example. And is that a reasonable risk mitigation or risk minimization strategy? And then you could make the same argument about myocarditis, although I view that as somewhat different as a vaccine-associated adverse event than TTS. So I think we're kind of, again, saying similar things in different ways, but how do we best minimize risk And can that risk be minimized through clinical considerations or through what the vote language is? Over.
Thank you, Dr. Daly. Dr. Rockwell?
Thank you, Dr. Lee. Pamela Rockwell, AAFP liaison. I started with my hand raised to ask about clarification on number of doses to be given, but now I just want to give a quick comment as a family doc on all the comments that have been given in the last 10 minutes. I agree with you, Dr. Lee, about the aged 18 to 64 years folks who are at increased risk for exposure and transmission because of the effect it has on our workforce, our single mothers, productivity, on and on and on. And I think, as Dr. Daly says, if we give more guidance rather than sort of the thought to consider maybe one vaccine over another given your sex or age, that might be helpful for clinicians who are very busy and it's very difficult to keep all this straight. But my original hand up was about the total number of doses at this point in time, today, October 21. My understanding after Dr. Fink spoke is it's number 4. Total number of 4 doses in about 5 months. That'll be true for those who are moderately to severely immunocompromised who've had a primary series, say, of an mRNA vaccine, then they got their 3rd dose. They are then eligible for a 4th dose. Is that correct? And if so, can we put that in writing saying this is something currently true at this point, and if you're not immunocompromised, maximum number of doses is 3.
Dr. Rockwell, thank you so much. We appreciate that. We are going to confer with our FDA colleagues offline after the meeting, and we will absolutely make sure that that is clear and in writing. But I just don't want to confirm without additional discussions. Thanks.
Okay, thank you. Dr. Goldman.
Thank you, Jason Goldman, American College of Physicians, but speaking individually. I want to echo some of Dr. Long's comments. I was very concerned last time about how permissive the booster recommendations were in absence of true data. And my concern with this is we don't necessarily have the data, and it seems almost as if the policy recommendation is trying to over-explain to shore up the fact that we really don't have the data to support it. It might be even easier to reflect what is going on the ground floor anyway, which is anyone who wants a booster is getting it anyway. So if we almost have more permissive language to say we don't have the data to support all of these decisions, we have some harm, we have greater benefit. If you want to get a booster, you can get a booster. And the reason why I say that is because these recommendations are in some ways asking the individual to decide on their underlying risk and medical conditions, because the reality is they're not consulting with their physicians in all cases. They're just going out and getting booster doses. And I worry that if it's too prescriptive or if it's too wordy, we are either going to miss the ability to give people boosters who really should be getting it, or people are just doing it anyway and not necessarily having the support of the language to do it. So perhaps putting in anyone who wants a booster is aware of the risk and they can get a booster if they choose to. Over.
Thank you, Dr. Goldman. We're going to move on to Dr. Freihofer.
Sandra Freihofer, American Medical Association, speaking as a practicing physician. I really think y'all have done a great job with these clinical considerations. I think they're helpful. I think you got it right. They allow the flexibility for CDC to stay nimble and more quickly address changes as there's new data. I love that we have the mix and match option. It gives us the flexibility we need for effective and efficient vaccine implementation, including flexibility on which product to use, and when we have patients that might prefer a certain product, and also considering their specific risk factors. And as a practicing physician on the front line and as a mother of another frontline practicing physician, I appreciate the option of being able to get a booster to maintain maximal protection against COVID, because I think we just have to keep our healthcare workers well. And I also greatly appreciate Dr. Fink's contribution in clarifying how we can best keep our immunocompromised patients safe. So I think y'all have done a great job.
Thank you, Dr. Freihofer. We're going to move on to Dr. Zahn.
Yeah, thank you, Dr. Lee. Matt Zahn for NACHO, but I guess speaking on my own behalf, I guess I'd just like to echo Dr. Goldman's comments about what's going on in terms of facts on the ground and where we are. That, certainly a large number of people, have the potential to be vaccinated, and I think people are making their own decisions. And I think one of the difficulties that we're just running into from a public health side is the risk criteria that exist here, specifically, work site based. Like there's no effect on person's risk based on their work site, but their social situation, whether they live in a large multi-generational household, their personal social behaviors, what the burden of disease in the community they're living in is, those are all probably bigger drivers of person's individual risk for COVID. And I know obviously we're working also with what the FDA guidance is, but I think in order to get to a guidance that really makes sense, it has to take those other risk factors into consideration. Another comment I'd make, and maybe I'm on the other side of what a lot of people are saying here, but just logistically and operationally, I certainly agree with having providers and patients having the option of maximal option in terms of what sort of vaccine booster they want to receive. At the same time, if there's no guidance, I just think that there's potential logistical operational issues. You can get any kind of vaccine when you want to. So I think there's a balance there in terms of, yes, offering as much leeway as you can, but giving some individual guidance for providers to interpret as they come in and see their patients. So thanks for the time.
Thank you, Dr. Zahn. And I think you're echoing what many of us are thinking, which is the continued need for patient education at an appropriate health literacy level and in multiple languages will continue to be an important priority. Right now, what I'd like to do is, just 1 second. We're going to take a 5-minute break, and we will return at 48 after the hour. Thank you, everyone.